for again giving me this opportunity. And so far you have seen the surgeries by masters where we will feel so easy to do DMEK, but I'll also share my experiences or others who are in my category who are still learning, so we may come across many problems. The first thing was what we should understand when we are switching over from DSEK to DMEK, that these two techniques are entirely different, and what we have learned in DSEK we can't apply directly to DMEK. So it's like switching over from manual CCS to FACO. Entirely different techniques we have to learn, and some of them we have to de-learn what we have learned in the initial DSEK. So starting from the tissue preparation, we have discussed this already. This is only for demo. I used a very old age donor cornea, where you can see the cornea will behave like a piece of plastic paper and easily break. So initially we may prefer a little older tissue so that unfolding will be easy, but preparing a donor tissue may be very difficult. And not only there, even it can occur even in masters like Siddharthan's hand, where obviously looking like a good cornea, but at the last stage when he is trying to release it from the cut piece, and there also like the tear occurs. So sometimes we may end up with some small tags or a tear, but still if you have about 80% of tissue, you can still go ahead and do the surgery. Like still we can escape from by doing the transplanting this graft. And coming to the recipient side preparation, we have to remember that this is a very less forgiving surgery. Like we have to remove all the tags, if we are using visco, nothing should be there in between the recipient area and the graft. So I prefer to do it under air whenever possible, so that we can see the tags at the edges easily, so that we can remove them meticulously, so that the graft adhesion will be better. And this we have just discussed the tissue flying out. See this, as mentioned previously, the surgeon is trying to close the wound also, even then as it just flew off. So it can happen, but luckily that the surgeon was able to retrieve the tissue and went ahead and got a good result. And I want to share one more thing. Like it can happen anytime. It need not happen only after injecting into the anterior chamber. As the surgeon was just checking the orientation and other thing, it just came out. So we have to be very careful. Sometimes this also can happen. And poor visualization is another problem as we are unfolding the tissue especially. So this can happen in long-standing corneal edema, or if the tissue is not stained well, or due to manipulation it got destained. So this is one another example. Like now you can see a lot of edema, so it's hard to even make out the tissue there. And then as the surgeon trying to, that's it, the graft is gone now. We don't know where. I think it went actually into the pupillary area, through the pupillary area behind the iris, and later he was able to retrieve and use it, but still in a sometimes this can happen, and especially if the view is not good. So that we have to keep in mind. And the unscrolling, again the same, the doctor asked this question, this kind of a cigar-like tightly scrolled tissue. So I think Rajesh Fogla described this some time back. So I used to enter the scroll area with the cannula and a small burst of fluid, we can unfold it. And if you are very confident about the orientation, we can even try to use that to unscroll the tissue. And sometimes a large, especially large graft can be folded like this, like a origami graft they call, and then we have to first straighten it before trying unfolding it. That sometimes it may be difficult. And this bleeding, again, we have to be very careful. I don't have a video to show how difficult it will be to stuck on tissue to manipulate, but we have to be careful. Whenever there is a bleeding and wherever you touch, you have to be careful. And I too also, I am not a big favorite of this PA, from where this ooze can happen. So nowadays, sometimes I totally avoid PA also. And there are some reports that without PA, we can go ahead and do the procedure, or we can go for a YAG PA. Again, this inverted triangle Dr. Rajesh was talking, but still even with all that preparation, I noticed that S was upside down. Then we have to deepen the tissue, anterior chamber, and then gently roll on the tissue within the anterior chamber, and then we have to go ahead and place it properly. So really it has to be rolled on in the anterior chamber itself. Then we can go ahead and do it as normal. And a decentered graft sometimes can happen at the end when we are injecting air. The graft tend to go towards one side and got this happen in DSEK also, but easily we can manage there by tapping. That cannot be done here. Again, you have to replace that air bubble with fluid and refloat it towards the center and then go ahead and position it. And sometimes again, this is another reason why I don't like PAs nowadays, especially somehow I tend to make a large PA. So I try to inject at the end the air. As I remove the air, I notice the air is again gone. Like you can see the fold of tissue at the inferior edge also. So it went behind the iris, then I need to again remove it and then reposition it. So this also can happen because of a large PA. So that's why nowadays without PA also we can go ahead. So the another problem, pupillary block glaucoma can occur postoperatively, especially if you leave behind a large bubble which you have not removed in time properly. And donor tissue dislocation is more in DMEK than in DSEK. And first we have to make sure that orientation is correct before to rule out why that this happened, to find out. And in the first week, any time it can happen. It may not be only the next day itself. Next day, what appear as a small, shallow detachment can progress to a larger detachment within few days. So we have to closely follow this patient and then we have to go for a rebubbling. Many people prefer smaller graft to manipulate, easy to manipulate, but then we can end up with peripheral bullae. So patient may remain symptomatic in these cases. Primary failure can be more than in DSEK, especially learning time. Need not be only due to the donor factor, it may be due to the very complicated recipient pathology also. Graft rejection is very, very low in DMEK. That's a main attraction for this procedure, but still it can happen, and very carefully we have to follow this patient to look for even appearance of small few KPs, and then we have to go ahead and manage. Graft infection is not so common here for us as compared to PK, but in the American Academy, the Eye Bank Association of America, according to them, the infections in EK is more than in PK. And as Dr. Basak pointed out, because the surgery starts in the eye bank, this is one of the theory that it may be because there it is handled and longer time and then it is transferred. That may be one reason. We don't know the exact reason. But it can happen. This is one of our cases from one of our center. Early seedling you can see, and within days it progressed. ASOCT clearly indicated that. Very difficult, because difficult to get the material even for the proper culture and identification. Mostly it is fungal, and Candida and Aspergillus are found to be common even in EBA study also. This case also was Candida. And the very important thing, we have to trace the mat tissue, the other donor tissue where it is being used, and then recall the patient and closely follow. That is very, very important, because in 2/3 of these cases, they can go for infection also. And in conclusion, this is a very elegant surgery, but we should remember that technically it is different from DSEK. So when we are switching over, we have to de-learn certain things and we have to learn certain tricks, which is very unique to DMEK.